Thank you, Jennifer. Thank you all for coming to this wonderful program this morning. And we have such wonderful partners. I could go on and on for days talking about the wonderful things. I think it kind of all got summed up when I saw that video on the off-key corral. I really got choked up because that is kind of the crux of what Neuro Challenge is creating in this community is things that allow people to be who they are and to forget about having Parkinson's and to be a normal person as much as possible. So thank you to everything that everybody does. It's wonderful. Okay, so today I wanted to talk to you about a couple of new developments in Parkinson's disease. Can you hear me okay? Good. And so along the way, though, I would like to first review a little bit of history of Parkinson's because it's interesting to me and hopefully to you as well. There's things that we can't really cover today, like what is Parkinsonism, and those sort of extra little small topics we try to cover, and those go on our website at some point. So if you've been to our other seminars, you're going to see a few slides in here that I've had before, but also there's other topics that will be on our website from years before or from even months before. That includes the other doctors that come to the other parts of our education program at the Expo every year as well. So again, you can go back and review those or watch them at your leisure. But as Jordan was saying, there's such a huge amount of information to know about Parkinson's, we can only concentrate on a small part. And I tend to go down a little rabbit hole every time I go make these slide presentations. So hopefully it won't be too crazy. So let's talk about a little bit about what Parkinson's is. So this is a typical slide that I usually show at all my presentations because it goes back to 1817. This guy, James Parkinson, he is the one who first discovered that there was a grouping of people that he saw walking through the streets of London that had similar sort of characteristics of being hunched over and having tremors. And so he was able to find 6 of these patients and kind of look at all of them and try to figure out what was going on with them. So what he describes is still the sort of things that we concentrate on now. So this little graphic shows the gentleman. As you can see, he's kind of hunched over and he's got decreased facial expression. He's got a tremor in one hand, which is usually what we see with Parkinson's. It tends to mainly be in one hand. Some people don't have a tremor, and we'll talk about that in a little bit as well. But most people that have Parkinson's, if they're untreated, will start to look more and more like this graphic of this guy walking bent back, kind of hunched over, bent knees, shuffling gait, decreased facial expression and blinking, and a soft voice. These are the things you can see from the outside. We'll talk more about that because there's actually a lot going on at the inside as well that you don't see. This graph shows what we call resting tremors. So on the right, there's a guy sitting in a chair, and his right hand is tremoring. And as soon as he starts to move, the tremor goes away. That's a Parkinson's tremor. The other woman has what we call essential tremor. She moves her hands out, and they continue to shake until she puts them down, and the shaking goes away. That's a different condition called essential tremor or familial tremor. It's very hard to figure out what you have when you come into the doctor's office. We often don't know. I would say probably 30% of the time we kind of say, well, it's Parkinsonism, tremor, we don't really know. So sometimes people look exactly like this, but a lot of times they don't. So we mentioned soft voice, decreased facial expression, freezing when people are walking, when they try to move their feet get stuck on the floor. A lot of times that causes falls, and falls, of course, being one of the causes of Parkinson's patients dying from that, about 20%. Eye movements are often affected as well, not being able to look to the left or the right very well. And in this little picture of Michael J. Fox, you can see his hands are like this, and that's called tenting. So that's what happens with people with Parkinson's. They tend to get a hand that will then be cramped like that. His handwriting becomes very small and hard to read. But the other things that are happening below the surface are probably more important in terms of what goes on in your life from day to day. We call those the non-motor signs and symptoms. So from the psychiatric perspective, people get depressed, they become anxious, they can become apathetic, and that happens in about 50% of people in one of those mood problems. As time goes by, people are more likely to become cognitively impaired. So by about 15 years, 90% of people will have some problems with cognitive impairment. and memory loss. And sometimes later on people will also hallucinate. REM sleep gets disrupted and people will thrash out in the middle of the night, talk, call out, smack their spouse. Some patients their spouses have to sleep in a separate room because of that. And then people often have trouble with their sense of smell. 90% of people with Parkinson's begin with a loss of sense of smell. And then inside of the gut, as you just heard from Jordan, there's a lot going on in the gut in Parkinson's. So the autonomic nervous system is the part of your nervous system that automatically controls things like your heart rate and your gastrointestinal system. What we see in Parkinson's is 90% of people have constipation. 30% of people have a slow stomach that doesn't empty fast enough, and it's called gastroparesis. And that gastroparesis causes people to have difficulty with gaining weight. They tend to lose weight. They eat half a sandwich and they're done. The heart rate doesn't normally respond when you get up out of a chair, and so it doesn't pump blood to your brain, and you get lightheaded, and people tend to pass out. That's called orthostatic hypotension. People tend to drool, they get abnormal sweating episodes, and they have sexual dysfunction. Okay, so let's switch gears a little bit. We're going to talk about the history of Parkinson's treatment. And here's probably the most famous internet meme in the entire world. Some guy's with a girlfriend and is looking back, looking at someone else. We're going to look back at history, and we're going to look at how Parkinson's was kind of discovered and then what happened along the way. Because it's relevant to how we treat Parkinson's nowadays. So again, let's look at Dr. James Parkinson. So this guy was very interesting. He trained as a doctor. His dad was also a doctor. And he decided after he trained to be a doctor, he wanted to be a politician. Bad move, right? So nobody really liked him as a politician. So after 6 years, he went back to being a doctor. And then this is when he found these 6 people wandering around London, and also a couple of them were his actual patients. And they had shaky hands, and they had stooped gait, and he started to call it his shaking palsy. He described the basic features we talked about earlier. So a little bit later, in the mid-1800s, this doctor, Jean-Martin Charcot, this guy is the father of all neurologists today. So anybody that practices nowadays probably has some sort of academic lineage that goes back to Charcot. He was practicing in Paris, and he was a professor at the Salpêtrière hospital there for 33 years. He trained a lot of neurologists. He made them famous right then and there underneath him. He's the one who coined this term, Parkinson's disease. He was very adventurous in terms of giving people medications and trying to figure out how to treat them, because nobody knew what to do back then. But he did recognize that there are separate subtypes of Parkinson's. Some people have a tremor, and that's probably 90-95% of people have a tremor with Parkinson's. About 5 to 10% don't have that resting tremor. He's the first one to recognize that. So he tried a lot of different treatments for Parkinson's. He tried telling people not to exercise. He tried to get them to exercise. He put them in hot water baths. He had a traction device he would suspend them from. He had told them to reduce their stress, which we also tell Parkinson's patients today. Even, stress makes your Parkinson's symptoms worse. He recognized that. He also had a patient that came to him one day and said they'd been on a train ride and their tremor was better. So he thought, well, maybe vibration worked for Parkinson's, and that's where that whole idea came from. Have you guys seen those vibration gloves? So you can buy these gloves to help with Parkinson's. What they do is they vibrate, and that whole idea is, it's 150 years old. And then he did said have people exercise, but he also told them not to exercise. It wasn't clear what to do about that. One of his students used electric shock to try to treat Parkinson's. It didn't work out too well. But he also tried medications. One of his students, Gilles de Tourette's, was this guy, you've heard of Tourette's syndrome. He's the one who described Tourette's syndrome and takes in the face. But also because he worked with Charcot, he developed this vibration helmet that he would put on people. So here's a picture of this helmet. You can get those at Walmart now, I'm pretty sure. There was also a vibration chair here that they would use. And they had, limited success. It helped a little bit with some of these tremors, but it wasn't something that they implemented permanently. So we're going to talk a little bit about drugs right now. It'll become clear in a while. So they didn't have a lot of things to treat people back then. They had a very limited amount of medications. So one of the things they had was this plant called belladonna. Belladonna is an alkaloid that comes from this plant that can be used medically. And what it does is it's an anticholinergic. So acetylcholine is this neurotransmitter in your brain, and it helps to block that neurotransmitter. And along the way, it can help with things like diarrhea, anxiety, psychosis, nausea, and it's still the basis for things we use like Dramamine, those little patches you can use behind your ear, you know, meclizine, things like that. Those are all based basically on belladonna. But it also has some bad side effects, including hallucinations, dry mouth, and some memory issues, memory problems. So when Van Gogh was stuck in the hospital, they were treating him with this drug called digitalis for his heart, but they were also giving him some belladonna alkaloids. And we think that that's probably where he came up with these weird visual changes that he had, where he would paint these wonderful paintings. So the other drug that they had at the time that was known that was something they could use was ergot, and that's a little fungus that grows on a plant. And it's been used for hundreds of thousands of years. And one of the things it used to be used for was to make people hallucinate for different religious reasons, festivals, things like that. But also, we discovered that people in the past were using it to stop bleeding. We were also using it to induce uterine contractions in women who were not getting birth yet. So it had a lot of different uses. So the neurologist knew about those two different drugs, right? So they also knew about morphine, but they also knew about belladonna and ergot. So when all you have is a hammer, everything looks like a nail, right? So no matter what the condition came through, you know, I guess they could, say, okay, I think you need to go on some belladonna, and then pharmacists would walk in and be like, hey boss, we're out of belladonna. And they go, okay, I think you need to try some ergot. So that's what they used. And Dr. Leopold Ordenstein was another student of Charcot. And he's the first one who figured out that there was Parkinson's disease, and there was a separate thing that they saw called multiple sclerosis, which was very different. But until that time, they were both lumped together as Parkinson's disease. He's the one who started using belladonna on patients and found that it was helpful for reducing their stiffness, reducing tremor, and made them feel better. And then Dr. Charcot was working with him at that point, and he added some ergot, and ergot has dopamine in it. And so with a combination of belladonna and ergot, they were able to treat patients. Another doctor, this is a British doctor who's not surprisingly a student of Charcot, Dr. Gowers, he's the one who was working with patients with muscular dystrophy, but along the way he also was studying Parkinson's, and he wrote a whole chapter on Parkinson's, which was the first kind of comprehensive look at Parkinson's. He was using opium and cannabis for Parkinson's. Now, one of the things I wanted to show you here is this guy on the left before opium and cannabis, and then afterwards. So back in the 1800s, nobody smiled. This is not actually a Parkinson's patient, but I tried to find a picture of someone smiling from the 1800s, and they cannot be found. This is one of my heroes. This is Dr. Santiago Ramon y Cajal. So before he came around, we thought that the brain cells were just these globs that were next to each other, just like a big ball pit. And he used these stains, and he figured out that individual neurons in the brain they're individual, like little people. They each have a lot of different connections, and he was able to use these stains to do this. So one of his eventual colleagues was able to find that when we looked at the brains of people with Parkinson's back in at the brains of some people who had autopsies, sometimes you would look at their midbrain and they didn't have any of this black substance called substantia nigra. Back then they didn't associate it with Parkinson's. All they knew was that there were some people who had an abnormal midbrain. And that was Dr. Bussard that figured that out. And then in 1957, this Dr. Carlson figured out that what that black substance was in the midbrain was dopamine. And here's the structure of dopamine. There'll be a test on this later. I'm going to ask you to recreate that. And then just a couple years later, Dr. Hornikiewicz found that people who had Parkinson's, that's what was missing, is they were missing their dopamine in the substantia nigra in the midbrain. So he didn't want to get in trouble himself, so he convinced one of his students, Dr. Berkmeyer, to inject Parkinson's patients with IV dopamine. So, he had this dopamine in his lab, and this is a true story. So he gave Berkmeyer that dopamine, and he said, hey, go try this, and if you get in trouble, I don't want to know about it. And people got better. They got dramatically better, okay? And so then Dr. Hornikewicz stepped back in and said, yes, good job. So here's one of their quotes. Bedridden patients who were unable to sit up, patients who could not stand when seated, and patients who, when standing, could not start walking, performed all these activities with ease after levodopa. They walked around with normal associated movements, and they could even run and jump. The voiceless, aphonic speech, blurred by palallalia and unclear articulation, became forceful and clear as in a normal person. So it was so dramatic that they knew they had hit upon something very important immediately. So then in 1967, Dr. Bartolini added this dopamine decarboxylase inhibitor, which we all call carbidopa nowadays, right? And that seemed to help get more of this drug into the brain. And then in 1969, there was the best trial you could have was a double-blind, placebo-controlled trial, right? So I'm big on those. That's where you don't know what you're giving the patient, they don't know what they're getting, and there's also a placebo in there somewhere. So it's like a big shell game. Nobody knows what's going on until the very end. And so that showed clearly that levodopa was helping patients with Parkinson's, there was no doubt. And that was important because before all that, Dr. Hornikewicz would go to these meetings for Parkinson, for the neurology societies, and he would say, this levodopa really works, you gotta try this stuff. And they would just kind of go, ho-ho, all right, sure, buddy. And after this trial came out, we knew for certain that it actually did help. And then Dr. Berkmeyer came back into the situation there, and he started adding the dopamine decarboxylase inhibitor to levodopa, and he found that it worked even better. So this is a picture of the L-dopa molecule on the left, and it has to go through this enzymatic process to get converted into dopamine. So that is what we block, that dopamine decarboxylase. So levodopa itself doesn't get it, it can get burned up in the peripheral nervous system. We want it to actually get into the brain. Cinemat came out in 1975 from Merck, Sharp, and Dohme. And that's what most people take with Parkinson's nowadays. It's carbidopa levodopa, we call it Cinemat, because the way they named it was sin is without, and emet or emesis is vomiting. So that's the actual origin of the term Cinemat. It's no vomiting. Now, the reason we have to do this is because in those original trials, when you gave people levodopa, 90% had nausea, 55% of them just frankly vomited. They felt better, they were moving around, but they also felt terrible at the same time. So this was a huge leap forward to add the carbidopa. So there's a part of the brain in the back here, you see a little circle, that's called the area postrema, and that area is very sensitive to dopamine. So it's not sensitive to levodopa, but once in the bloodstream, once it gets converted into dopamine and it hits that area postrema, it makes you vomit. So how do we keep the levodopa in your bloodstream from getting converted to dopamine before it gets into the brain? How do we stop that? Well, this dopamine decarboxylase, or carbidopa, is what does that. It blocks it in the peripheral bloodstream so it can actually get into your brain, and so you get more in your brain and you get less vomiting and nausea. You can still get nausea and vomiting, of course, but it's a lot less. So getting back to history, we knew for that apparently going back hundreds, maybe thousands of years in Indian literature, that in India people were using this bean called mucuna, and mucuna pruriens contains levodopa. You can actually buy it over the counter. It does work. There are some limited trials that show that mucuna works for Parkinson's. It's levodopa. It's the same thing as in the tablets. But the problem with it is it's unregulated by the FDA. You don't know what the concentration or the amount you're getting. So generally it's not preferred in my mind to using actual pills, plus there's no carbidopa there. So looking at traditional medications that we use for Parkinson's treatment, of course levodopa getting converted into dopamine. There's also dopamine agonists. Have you guys heard of these? I'm sure that we used to use a lot more of these, I think. So those are things like ropinirole, pramipexole, or tigatine. So we still use those, but not quite as much as we used to, I think. They do have their own set of side effects. MAO inhibitors, those block the breakdown of dopamine in your brain or in the periphery. That's like rasagiline. COMT inhibitors, entacapone, now we have opicapone. Those block the breakdown of dopamine as well. And then we have amantadine, which is an NMDA receptor antagonist. There's going to be a test on that later, just like there is going to be Enterobacteriaceae. Okay, we're going to spell that one later on. All right, so basically these are the traditional medications that we use for Parkinson's control. So on the left, you see the structure of dopamine, and if you have any chemistry background, if you look at these different agonist molecules, they all have a couple of things that are very similar to the dopamine, which is why they stimulate the brain in a very similar manner. Now there are several problems with dopamine and medicinal treatments for Parkinson's. One of those is called motor fluctuations. So as time goes by and you've been on these medications, they become less effective, not because you're getting acclimated to them like you are to morphine or to other things like that. Your brain is making less of its own dopamine over time, so we're having to put in more and more dopamine from the outside, and it lasts for a shorter amount of time, so it's called motor fluctuations. And then a lot of people also will develop dyskinesia, which is additional extra movement and kind of wiggling around a lot, like Michael J. Fox. Another problem is you can take a pill and maybe it doesn't even get in, it won't kick in, or it's too slow to kick in. It can cause nausea, it can cause low blood pressure and dizziness, it can cause sleepiness, hallucinations. So these things all are related to basically dopamine functions in the brain. The other drugs, the belladonna-based drugs, basically anticholinergics, cause dry mouth, dry eyes, constipation, memory loss, and hallucinations. So none of these are perfect treatments, of course. But, thankfully we have these treatments, but we have a lot more advanced treatments nowadays for Parkinson's than we did, in the 60s. But they're all still kind of based on the same principles. So those dopamine agonists we talked about, those activate the dopamine receptors in the brain just like dopamine does. But they have their own side effects as well. So one of those is called impulse control problems. Buying, gambling, collecting, and sex. Those are the things that we typically see. 5 to 15% of people who go on these medicines have issues with that. So you may have a normal behavior going out and buying a lottery ticket once a week, but these people are going out and buying $500 worth of lottery tickets a week. So those sort of behaviors, which they kind of get out of control. Dizziness is another problem. Sudden sleepiness, falling asleep at the wheel while you're driving. That's been seen several times with these medications. And then it can kind of be more dependent or habit forming. So if you run out of them, you can have a pretty severe withdrawal syndrome. So levodopa we had talked about already pretty well. It is very effective and recognized that way. It takes about 5 to 10 years to develop the dyskinesia and other side effects. 90% of side effects within 10 years. So how do we get the dopamine to work better so you have less and less of that wearing off phenomenon? So as I mentioned, we can give things to block enzymes to make it work better inside the brain. We can also enhance your own production of dopamine in the brain by making you exercise. And there's other things we can use for that. This is just a picture. It's kind of pretty small, probably hard to see all these components. But basically what we're looking at is this one cell, the yellow nerve terminal here, the axon, is dumping dopamine onto the purple cell at the end. And those little orange receptors there are waiting for the dopamine to come and bounce off of them. So we can insert dopamine agonists from outside the cell, and they float in there and stimulate the cell in the same way. And then along the way, we can block the breakdown of dopamine in the brain, or we can block it in the periphery to allow more dopamine to be available. So we talked about some of the traditional medications for that: carbidopa, levodopa, amantadine. Ropinirole or Requip, Pramipexole, those are the dopamine agonists, along with rotigotine, rasagiline, selegiline, those are NAO inhibitors, apomorphine or apokine injection, it's a dopamine agonist. Entacapone is a drug that helps block the breakdown of levodopa. And then some of the, quote, newer medications, we have this inhaler called Inbrija, which is just levodopa, and you load up a little capsule and you puncture the capsule and then you breathe it in, and it starts to kick in about 10 minutes. So it's nice way to get you to kind of a bridge if you're early in the morning and your medications aren't kicking in or you're having a hard time in the day, you can use this inhaler called Inbrija. There is a pump called Duopa, which is inserted through a G-tube into the stomach, and you wear a little cassette and it constantly pumps this gel into your system, into your stomach all day long. There's a drug called Nuplazid, which treats hallucinations. So hallucinations being, I think, one of the more debilitating kind of problems that people experience later on down the line with Parkinson's. Those hallucinations can start out with just things off to the side and kind of not be really a bother. I mean, see a little cat run across the vision, but sometimes they start to become more right in front of you. My dad had Lewy body disease, he was Lewy body dementia, and he would see like kids dressed up in harlequin clothes sitting on the sofa in front of him, and he would walk over to them and then they would eventually dissolve and go away. And I was concerned about that, but my dad thought it was cool. He was an artist, so he would like make pictures of them and things. Gocovri is an extended release amantadine medication that's used for dyskinesia and for off time in Parkinson's. Rytari is an extended release carbidopa levodopa, and I should disclose that I have spoken for Rytari on their speakers bureau as well as for this drug Crexont we're going to talk about. Dahivi is a drug that is carbidopa levodopa in these little quarter tablets. They're all kind of stuck together, and you can snap them in half and you can snap them in quarters. It's kind of useful for taking lower dosages as medicine. Sulfonamide or Xadago is another MAO inhibitor. Kinmobi is, I think, not available anymore, but that was a little sublingual film you can put underneath your tongue. Ongentys or obicapone is a blocker, is an enzyme blocker as well, and that helps to extend the time that the carbidopa levodopa is working in your brain. And Crexont, we'll talk about in a minute, and Vialiv subcutaneous, we'll talk about that. Okay, so one of the big problems with Parkinson's is this thing we call on-off fluctuations. So in the very beginning of Parkinson's, you can see on the left, this white area, this kind of, see that white cone? So the white area is, you give someone any dose of carbidopa levodopa and it's great. They feel better, they have mild Parkinson's, it helps them. Low dose, high dose, they'll still feel better. As time goes by, there's that little window for feeling good gets smaller and smaller and closes down, so that over the years, that dose becomes more and more critical, exactly how much you're getting. If you get too much, you start to develop dyskinesia. If you don't get enough, you get the freezing. And that becomes a real problem, usually by 10 years, 15 years down the line. So how do we get around that? Why do those things happen? Well, part of the reason is we think that brain cells become very sensitized to the levodopa. Another is that you're not making enough of your own dopamine yourself. But more kind of practical reasons, we see these pills get stuck in the stomach. We have endoscopy pictures of Cinemat stuck in the stomach, and it just doesn't move out of the stomach. And then people also have a slow emptying process in the stomach, and so even if it's dissolved in your stomach, it's not getting into your small intestine where it needs to go. Constipation also backs up the entire system and interferes with the uptake of the medicine. If you're eating dairy protein, as you heard, with your medications, then it tends to reduce the effectiveness by about 15 to 20%. It's not a sin to take it with food, but at the same time, it's much better to take it 30 to 60 minutes before you eat. And then poor compliance. This is probably the biggest problem. I have a lot of patients who they take their medications, and it's 3 or 4 times a day. It's really hard. By noontime, they forget their noontime pill, or their afternoon pill, or their evening pill. That happens very frequently, and that's as time goes by. With Parkinson's, if you've had it for 10 or 15 years, that becomes more critical. It becomes a much bigger problem. So one of the ways around that is an extended release carbidopa levodopa. This is Crexont. I think it just came out in October. And it's got some significant advantages. It's less frequent dosing, fewer capsules per day. It releases the levodopa very slowly into your system. And the studies that were done with it show more what we call good on time. In other words, your medications have kicked in, and you're not having the dyskinesia, and you're able to get around and do the things you want to do in your life. It does have side effects, just like any levodopa derivative of sleepiness, low blood pressure, nausea, dyskinesia, hallucinations. All those are the same as you would have with the Cinemat. And here's just a little graphic here, Crexont name. I think I'm not sure exactly how they derived the name. Probably Donna can tell you this, but to me it's like CR, controlled release, extended on time. I think that's basically what the thought process was. And it comes in 4 different sizes, 4 different dosage strengths. This is a very bad slide that I downloaded off the internet that I got in trouble with April for because it's a little blurry. But it does show that you have more on time with the Crexont. So this is a little better. So this slide shows the smaller curve here is regular Cinemat. The IR-CDLD is Cinemat. In your bloodstream, it goes up and it comes down pretty quickly. And then when we developed Rytary is the middle line, the purple one. You can see you have a lot more time on. That this medication is providing a lot more elevated levodopa in your bloodstream. And then Crexont is kind of the next generation beyond that. And that's the green line on top, and that gives you even more on time. So with Crexont, relative to Cinemat's giving you 1.9 hours of on time, and Crexont's 4.8. Rytary is kind of in the middle of that, so 3.9. So it's a significant leap forward, in, I think, in giving us more on time to the medicine. And this is just a little graph. So a quarter of this pill is made up of regular immediate release Cinemat, and the other 3/4 is this little gel. It's very interesting. This gel sticks onto your small intestine and then slowly releases the medication all throughout the day as much as it can. Another thing that's really kind of groundbreaking, I think we've been waiting for this for a long time. It's called Vyalev. Vyalev is a subcutaneous administration of carbidopa and levodopa. It's like an insulin kind of system, or the insulin patch, the little patch here, it's got a little tube that goes to a box. I don't know if you've seen that people have that, but that's kind of been a game changer for a lot of people with insulin. This is a very similar sort of idea. It's 24/7. It's pumping this carbidopa and levodopa through your system. It's better than oral medications in terms of how effective it is. It's the only subcutaneous system we have. And it just works 24/7, continues to pump it through. You have to change the patch with the little tube to the pump every other day to move it around. It also can cause sleepiness, low blood pressure, nausea, dyskinesia, hallucinations, and some skin irritation. So these are just some slides. Again, I got that. One of the things I wanted to point out here is that the on time, versus people who are taking the oral medication is a lot better, and it's 24 hours a day. And they studied this in 4,200 patients, so this is very well proven with, again, placebo-controlled sort of situations. Here's just a graphic of the typical sort of dopamine up and down you see throughout the day on that left-hand graph there. And so what this does is, if you see the green line on the left here, it flattens that whole thing out so you don't get these ups and downs. And so as you can imagine, it's much easier to predict what's going to happen throughout your day. And so we get a lot more on time per day, 2.72 hours on average using this subcutaneous delivery system versus taking the carb-levo exactly on time every single time. So again, here's another a little graph of what that looks like throughout the day. It's much better. And also the nighttime release throughout the daytime is good because people get a lot of better sleep. So I'm sorry, this is really small and I have very bad vision, but look at, so So those people are getting 7 hours of sleep at night on Violet as opposed to 3 good hours of sleep. So I think that that's a pretty significant improvement. You know, sleep is a big problem with Parkinson's patients, right? I mean, you guys know that. Not just the REM sleep disorder, but then waking up and feeling exhausted, or you're waiting for your medication to kick in and things like that. So that kind of gets around that whole issue there. And here's a little graphic of the box and the little tube and a patch. So it's not permanent. You know, you stick this patch on your skin, and it actually comes with this really cool applicator where you put the patch and the needle on there, and you hit a little button, and it slaps it onto your skin, so you don't have to, stick yourself with a needle. You just press this little button, and it does it. And it's a very, very tiny needle, and it goes to a tube to this box. You can wear it like in a fanny pack or in your pocket throughout the day. So that just kind of reiterates what we were talking about before. But the dose is adjustable. It's not just a single dose. You can give yourself different dosages. 89% of patients thought that it was very easy to use, and 92% of patients were satisfied with the Violet subcutaneous system. And this is a graphic of all the pills you were taking a month with levodopa versus the Violet. Okay, so now we're going to talk about brain surgery for just a minute here. Okay, so back in 1908, these two doctors, Horsley and Clark, decided that they were going to try to reduce tremors by removing parts of people's cortex, and they wound up giving them strokes. Yeah, so this is that guy, he's like, yeah, how about no? We don't like that. So that was quickly abandoned, of course. And then in the 1930s, there was this wonderful neurologist up in Canada, Wilder Penfield, who they were trying to stop people's seizures by taking out their temporal lobe, but he was going in with this little electrode and stimulating and finding out what was going on with their language. And so they would try to save their language area during the surgery, because he could say, oh, if I stimulate this and the person starts talking, then we don't want to cut that part. So that was a big leap forward. And then there was another neurosurgeon who accidentally caused someone to have a stroke in a part of their brain during the middle of neurosurgery, and their Parkinson's got better. And they figured out that one part of the brain has to do with the basal ganglia, as we call it. And then other surgical things were tried all throughout the 60s, but not much happened at that point because we came up with carbon and levodopa, and nobody wanted to proceed with those sort of studies because it was working so well. But along the way, looking at pain systems, we decided to go ahead and stimulate the brain for pain, and found out it was causing other things like people's Parkinson's to get better by accident. There's two different sites that we use for the deep brain stimulation. One's the subthalamic nucleus, the other is called the globus pallidus. And here's kind of a representation of a brain and how it looks. You have the battery pack in the chest. And then the wire goes behind the ear up into the brain, and then there's a cap that connects the wire in the brain. And it is FDA approved for many years now. In Parkinson's, it was approved for tremor in 1997. This is not brand new technology. So this is over 160,000 patients have been studied with this by the year 2018, so many more since then. So one of the things I wanted to show you in this little picture was, you see this stick with these 4 gray things. Those are electrodes. So inside this stiff wire, which is the white, looks like a pen, there's actually wires inside of there that connect to each of these little electrodes. So there's 4 electrodes here. And that was the way it was originally designed. What we have now is really cool, because, so on the far right there, you see the original Medtronic electrode. Well, now we have 3 different companies making these systems, and what they've done is they've fractionated each one of these little ring electrodes into thirds, so that instead of having just 4 leads, you can have 8, maybe even more. You can have 16 leads, depending on how you cut these things up. So that's cool, because then you can stimulate much smaller parts of the brain. So this is looking down from the top, is at the stimulation. You see the green is the good part that we want to stimulate, and the red is the part we want to stay away from. Well, with the older electrodes, it would make an electrical field, and you would get both of those. It would stimulate both the good and the bad parts. Well, nowadays, we'll be able to just stimulate a part of the electrode. You can just aim it at the good part, the part that you want to stimulate, and avoid the part you don't want to stimulate. Very significant leap forward, very cool. Another thing that you've probably heard of is focused ultrasound for Parkinson's, and that's we use an MRI to locate the part of the brain that we want to burn, which is it's essentially neurosurgery, right? So if you have a tremor that is not responsive or you're not a candidate for deep brain stimulation, this is another option for Parkinson's. And there's a cap that's put on the head, and we used ultrasound waves. It's not radiation, it's not electricity, it's ultrasound, to heat up part of the brain. And that is effective as well. So that reduces tremor about 50 to 80%. So right now, at this point, it is approved for Parkinson's, for different Parkinson's symptoms, but I think most people have been kind of using it for tremor. And there's certain limitations on if your skull is too thick or too thin, you can't get it done. If you're certain other conditions, we can't do it. Okay, and that again has been FDA approved for for a number of years now, maybe 5 years. Okay, so in the end, how do we treat Parkinson's disease? Well, we have medications, we have surgery, we have great caregivers, we have pharmacists, dentists, physical therapists, occupational therapists, speech therapists, nurses, GI doctors, sometimes a neurologist. And so it's a whole team approach, and that's what we really have done with Neuro Challenge Foundation, is try to remember that the patient and the caregiver are really what's the most important. You know, I call Parkinson's a whole person disease, because it doesn't just affect your motor function, you know, or even your gut, or even your psychiatric functions. It affects you and how you interact with your family, how you interact with your community. And so that's why it's important to have this whole support network that we didn't have before Neuro Challenge came here to Sarasota. And that's what we really want to do, is have everybody looked at from a very comprehensive sort of a picture to help any way we can. And this is a slide of some of our wonderful volunteers and patients that we've had over the years. And there's one of our spinning classes. There's Jeff Torport goofing off. Just kind of to summarize, there's a lot of things we can talk about with Parkinson's, and you're going to hear a lot more, you know, from these speakers. There's things like medical marijuana. We're not going to hear about it this time, but you know, we did last time. There's new psychiatric medications and techniques, and there's new medications that are coming out. This is wonderful because we're able to provide these lectures in the expo for people that are from all over the country. These are world famous people. I would encourage you to sign up for that and to come. And then finally, one last thing. There's a large bucket down here. Can you guys see this bucket? I'm going to carry it around, and nobody leaves until the bucket's full of donations. But yeah, thank you very much, everybody, for coming. I think wrap up words here.
Do you feel like taking a couple questions?
Yeah, I'll take a couple questions.
Okay, great. I have a question, so if you can't, and we're going to get as many as we can together.
The new medicine you were talking about that was delivered like diabetic, we get insulin. So, Brian,
What's the question?
The subcutaneous.
the subcutaneous. Are insurance companies covering that?
I think that they're starting to, yeah. It's not as good now. A typical new drug, you know, a new system, not as good as it will be. I think right now, commercial insurance is paying for it. We're waiting to get Medicare to kick in as well. So if that's going to be coming down the line, it'll happen. It'll happen.
Yes, sir. What's the latest on the causation of Parkinson's? Why do we have loss of dopamine?
Why do people get Parkinson's?
Causes of,
Yeah. So why specifically those cells in that one part of the brain? You know, we have lots of brain cells. Why doesn't it concentrate there? Those cells that are in the substantia nigra, they have these little things that are called mitochondria, like all cells do. And those mitochondria, we call a powerhouse of the cell. is for some reason those cells are very sensitive to being overworked. That's part of the reason why they're the first ones to kind of go, because they're making this dopamine. They're already kind of taxed. We think that that's part of what the reason is. Now, why it happens initially, we really don't know. There's genetic reasons why people have it. It's definitely passed down in families about 5 to 10% of the time. But mainly, we think it's some environmental exposure. That's herbicides, pesticides, and fungicides. And the reason we know that is because, vets who went to Vietnam exposed to Agent Orange, they have an abnormally high amount of Parkinson's disease. People who lived around some of these fields out in California and other farming communities who used a lot of pesticides, they're at higher risk. Paraquat, which was on a lot of we were trying to kill marijuana fields, people would just smoke the marijuana anyways, and so apparently that's also a risk factor for getting Parkinson's if you're exposed to that. So we think it's mainly environmental, which would be nice to be able to figure out exactly what it is. It does come in through your nasal mucosa into your brain or through the gut. So we know that vagus nerve that Jordan was talking about, we know that we can watch you get Parkinson's in your gut and then watch it over the course of months to years, crawls up that vagus nerve, it goes to the back of your brain, and then about 5 or 10 years later finally makes it up to the substantia nigra and causes Parkinson's.
If somebody has DBS and say they had Medtronics and it isn't working anymore, can they get new leads and electrodes in there? They can show a new picture?
Yeah, so she's asking if you have deep brain stimulator and it's not seeming to work anymore, can we put in the new leads? And the answer is yes. It's not done for the faint of heart. It's something that you need to really consider and have a very good neurosurgeon to talk to you about how to do that if necessary. The answer is yes, in short, but also we're kind of scared to do it unless it's absolutely necessary. Because more brain surgery is more likelihood for having complications.
You answered some of the questions I was going to ask about environmental and working in areas where people inhale, a lot of things. And things like Repatha and nifedipine, it says that, sometimes people hallucinate and blood pressures go up and all of that. Can that, and then have constipation, can that maybe be a sign of contraindication or something?
Like the first sign?
Not a sign.
So
maybe a beginning though.
So yes, we have known for quite some time now that there's 3 risk factors for you later developing Parkinson's. One of them is unexplained constipation. Another is that REM sleep disorder where you're screaming out in the middle of the night, you have night terrors. And then, the tremor is, once you add on a resting tremor to that, your increased likelihood it goes up significantly. If you've lost your sense of smell, if you have all 4 of those things, plus, the 3 plus the tremor, you can write in your doctor and say, I've got these 4 things, and he can just write back and say, you have a 75% chance of having Parkinson's. Yeah. So those are very predictive. So that's one of the questions that you ask, your neurologist will ask you when you go to their office, family history, and then there's other historical questions, And interestingly, we did a series where we went back and looked at people who had biopsies of their colon, for polyps and things like that. And if you can see the alpha-synuclein there's a bad protein in Parkinson's. If you can see that bad protein on those biopsies, and you go back and look at what happened to those people later, 50% of them develop Parkinson's. So, and I think it's too expensive to test every single polyp for alpha-synuclein, but if we did, we'd at least be able to tell people, hey, 5 or 10 years later, you might get Parkinson's.
My question is, everybody talks about exercise as the holy grail for protecting ourselves. And I've noticed that when I exercise, even for short periods of time, my tremor gets worse for a little while. And then it subsides, but I thought that was kind of weird.
Yeah, any tremor gets worse when you exercise, especially if you're lifting weights. It'll make tremors worse, or if you're doing yard work or things like that, where you're actually putting a lot of strain on your muscles, the tremor will get worse. The parts that get better, we can see dopamine being produced in your brain when you exercise on some of these live MRI machine studies. And then we know from other studies that slows down the progression of the disease. I mean, it's very clear.
But why does the tremor get worse?
Why what?
Why does the tremor get worse?
The tremor gets worse because your muscles have become weakened. So any type of tremor, no matter what type of tremor you have, if you get a little weak, your tremor will get worse. But we also see that people who exercise are then walking better. So you go on a spin bike and things like that. They're less likely to have freezing. Their mood goes up. So, we've done studies of exercise versus Zoloft. Exercise is twice as effective as Zoloft at relieving depression and anxiety. And that applies to Parkinson's as well. As I said, 30 to 50% of people with Parkinson's get depression and anxiety. Exercise does help with that, for sure.
Hi, Dr. Sutherland. First off, thank you for all your the service that you give to this community. One real quick note, I'm a runner, and when my hands start shaking when I'm running, I start thinking, okay, I'm pushing it. I feel like it shakes a little bit more when I'm stressing my body a little bit. But my question is, can you give like a chronology in terms of like when's the best time to start going beyond like taking the pills or the extended, or moving into the extended release, anything like that? I mean, because at getting close to 10 years, I kind of have a vested interest in the chronology of that.
Yeah, it's a great question. When do you move on to the next type of therapy, like the extended release, carbon leave but when do you start to do that? If you're taking medications 4 times a day, that's kind of starting to be the break point in my mind where you're going to want to think about doing extended release. If you get up to 5 times a day, absolutely. If you're doing medications every 2 hours, that's definitely extended release territory. And then when you start talking about doing brain surgery, it's also kind of another extension of that. If your medications are no longer working and your downtimes are too frequent and your dyskinesia is starting to crop up, then that's the time to think about moving on to getting brain surgery. So that has to be like an ongoing conversation with your neurologist, as well as with your family and things like that. Some people are too old to get brain surgery. Some people say, heck no, there's no way I'm going to let you operate on me. So it's a very complicated issue. So moving from the regular carbidopa-levodopa to extended release, I don't think is much of a complicated issue in my mind. I mean, it's the same drug. It works much better in the long run. If it was covered 100% as a covered medication, all those drugs, I think you would all be on it. The thing is, carbidopa has been out since 1975. And so that drug is not expensive. It's easy to get. Every pharmacy carries it. Once you get the newer medications, it's harder to get a hold of them and get them paid for. But I do think that they work better.
Yes, Dr. Sutherland. I was had an article from the Florida Sun Sentinel the other day that talked about a new machine called the Exablade Prime.
Yeah. So Exablade is that focused ultrasound that I showed you.
Okay.
Yeah, so what it is, an ablation is a lesion that replaces the brain using a knife or electricity or heat. And so Exablade is the system that's used with the MRI to heat up the brain and make that little lesion that relieves the symptoms. Yeah, they're doing that in Orlando. Is that from Orlando, you said, Sun Sentinel? Yeah, well in Orlando they're doing and they're also doing it at the University of South Florida in Tampa. But Orlando has been doing it for a while and does a good job as well.
We're only going to take one more question, so we've got your hand up here.
Yes, what is the best treatment you can recommend for the Lewy body dementia? Someone who's been diagnosed with Parkinson's and then that only like 6 months now.
So Lewy body dementia is harder to treat. The Parkinson symptoms come on in the beginning, but then so does the cognitive stuff. And the Parkinson's or motor symptoms, they kind of simmer along and they get worse, but the thing that gets worse absolutely is the cognitive issues. So the first kind of go-to medication for that is an Alzheimer's medication called donepezil. There's a little patch, it's called Exelon or ribostigmine. So those patches can be tried, or the pills can be tried like right out of the box, like very early on. If that doesn't work and it's not helping with the cognition and hallucinations, then the next drug is called Nuplazid, and that's a drug that relieves, it's FDA approved for hallucinations with Parkinson's, and that helps to relieve that, you know. Nothing's perfect, but it definitely helps, and I've seen some people have some pretty amazing turnarounds on that drug. You know, but also, if you're on carbidopa levodopa, you know, another thing you can try is to reduce the level of carb-levo, and sometimes that gets rid of the hallucinations. And then, of course, the other things are just standard, you know, exercise, physical therapy, all the sort of Parkinson's sort of things we do anyways. So it's not really treated terribly different than Parkinson's. We start to concentrate on more of the cognitive stuff.
Okay. Well, thank you, Dr. Sutherland. Very